Hi, hope you're all well. I'm Viv and I'm the face behind Skinpharma Aesthetics in Stockton-on-Tees. Tonight, Sunny and I are continuing our journey using ultrasound in our aesthetics work, and we're going to just review some of the lives we've gone through recently. Hi Sunny, hope you're well. And we'll add Sunny on. We've got guests coming up over the next few weeks, so we'll talk about that shortly. I'll just add Sunny. We've been doing lives now for about 6 months. It's gone quickly, and it's interesting to see who we're going to talk to next. Hi,
Hey
Sunny.
Viv, how are you?
Fine, thanks. Doing all right. Have you had a good day today?
It's been busy. It's been busy. It's been a good day, obviously. Different types of treatments, fillers, medical facials, using our kind of stacked technique, cryotherapy,
Right.
and even got to pop out for lunch for a coffee. How about you?
Yes, yeah, busy. I was working this morning. I had a bit of time later on this afternoon to sort paperwork and bits and pieces out. But it was just today. I thought it'd be interesting for us just to look back and see what we've been doing over the last few months and review some of the lives we've done with lots of different specialists around the world. And it was just looking back over the last 2 months or so. We've talked to quite a lot of practitioners from all over the place. Was there any that gave you a lot of inspiration about your own work, do you think?
I think all of them gave inspiration. I mean, they're all very much specialists in their field. It was it was nice to that they felt that well they felt gratitude for joining us on these lives.
Yeah,
I mean, if we think of, for example, with Mariam, obviously from Morocco, and how she was using ultrasound for actually, not even injectable related, but um, visualizing and defining skin lesions, especially skin cancers. I mean, that was particularly
yeah,
insightful, I would say,
yeah.
even I suppose groundbreaking. Because I never considered using ultrasound to
No,
diagnose skin lesions. It's always a dermatoscopy
yeah,
approach.
yeah,
I mean, Martina, Australia's. I mean, I've been following her on her Instagram, and she's using different ultrasound in different ways. Obviously,
yeah.
Leonie has to be mentioned. Dr. Jose has just joined just as well. So Dr.
Yeah.
Jose from Tenerife, wasn't it?
I think Gran
Um,
Canaria is based
Gran
in the
Canaria,
Canary
sorry,
Islands.
my
Yeah,
bad. I'm thinking, yeah, Gran Canaria. Sorry, Dr. Jose. Jose. Yeah, so I think the overarching insight is that one, that people that have joined us are very passionate about using ultrasound,
yeah,
whether they're at the beginning of their journey, like Lynette, like us, or whether they're well established in their field and they're using this as an additional tool. It was really insightful. So how about you though? Who sticks in your mind, and who did you?
just like yourself, all fantastic people. All have got their own specialities, and they've got such a wealth of knowledge that they're quite happy to share with everyone. It's really fantastic to be able to speak to them. I enjoy speaking to all of them. To be quite frank with you, I think they've all got their own specialties. Lynette sticks in my mind because of the psychological issues involved with work and the fact that she never gives up in doing what she wants to do. And that goes with anything in life. I think if you really want to do something and you've got the determination, nothing can stop you. And she stuck in my mind and still does, purely because of that aspect. I think it'd be nice to meet up with her maybe in Northern Ireland, or if she ever pops over to the UK, to England, it'd be nice to see her over here. But again, Martina, great person in Australia, really nice thing to her. Mariam, professor of radiology, you couldn't ask for a more proficient person to speak to
Because
about the whole subject.
Viv,
Um,
you've done quite a few augmented scans for different people.
yeah,
What is it in your mind? Which scan is stuck in your mind in terms of the either the series of scans? Which one of you? Okay, so first question is, which one of you found really useful in augmenting?
yeah.
Which kind of case or clinical case would you say has been really useful in augmenting?
For my own work, based on the work I do, I've been using ultrasound guidance for masseter injection. So using toxin to help relax the masseter muscles at the back of the jaw. With scans carried
No,
out
no,
by
with your
Carolina.
no, no, with your AI, like the AI thing that you do.
Oh yes, well,
Not the AI,
when
sorry, it
I
hasn't been AI yet. Sorry, I jumped the gun. I fast
well,
forwarded a few years. No, what I mean is when you
oh
color code
yes,
it.
yeah,
Yeah. So
yeah.
which scan have you found has been the most interesting to do that with?
To be honest, all the ultrasound AI work that I've done on the scans, they've all been interesting, to be honest. And I learned such a lot about anatomy and about detecting tissue. When you look at a scan, you have to try and figure out what you're looking at in the different tissue layers. All of Leonie's scans have to be mentioned.
No, no, pick
Purely
one.
because
Pick one. No, no, pick one. Oh, you got it.
one
Everyone's
particular one
watching.
was
People have joined us, whether they are practitioners or whether actually patients.
there was
Pick one scan and describe why it was so useful, what you
yeah.
found interesting about it, and what you did to enhance it.
With one of Leonie's scans, she carried out an ultrasound scan of the area below the eye, so a medial scan looking at the area around the angular artery and around the tear trough area. And she had a patient come to her complications clinic in Rotterdam who had an issue with an area of tint. There was a tint to the skin, there was some inflammation, there were some problems I think the patient had. The practitioner that she had the treatment with wasn't able to solve it, so the patient came to her. She did a scan, and what she found was there was a vessel, there was a vein that was actually being pushed upwards by filler below it, and that was actually creating what looked like a Tyndall effect, but it was actually the vein itself that was pushed higher below its natural position by filler. So the CGI work involved detecting the tissues within the scan, and dynamically you were able to see the movement of the filler being dissolved. She actually carried out a guided ultrasound scan as she dissolved the filler, and you could see how the area dropped back down to normal following the dissolution. So for me, that was really an amazing piece of work to try and augment. It's not every day you see some problem like that, and it would be
No.
very difficult for, I think, somebody starting up deciphering exactly what they're looking at. You know, when they see a scan, you need a lot of experience to be able to identify an issue to begin with.
Because obviously, if you're not a sonographer, you haven't, you know, you're an experienced pharmacist, prescribing
Yeah.
pharmacist. But how did you approach identifying those different layers? Like, how do you, when you look at a scan, because you're not a sonographer, so you're looking at
Yeah.
it from first principles, basic principles, first
Yeah.
sight. How did you get into then color coding those areas? What did you do to then get knowledge of that?
It basically relies on your normal knowledge of anatomy, but the problem is it's trying to link that to a great image. It's very difficult. So you're trying to work out the basics. Where's the bone? Where's the muscle? Where's the skin? If you can work out the basics, you go from there. So a lot of the CGI work that I was doing was trying to decipher what I was seeing in terms of basic anatomy. If I could work out the basics, I was more able to look at the more intricate areas that needed to be identified. Leonie helped me a lot trying to work out what I was seeing. So did Carolina, radiologist over in Argentina. She was fantastic, but it took a lot of experience looking at scans again and again and again to figure out what you were looking at. And the problem is, even radiologists, even people like Carolina and Rosa Segrist, they don't just automatically understand exactly what they're seeing. They have to take some time and try and figure out what they're looking at. But with more experience, your proficiency increases. And with more and more of these scans that I've looked at, it's become easier and easier for me to figure out what I'm seeing. And because of that, I can augment it a lot more easily now than when I first started. But it's
So
purely
how many scans did you think you had to look at? And obviously you got help from people like Leonie and Rosa to look at, to obviously help identify what you were looking at. But how many scans would you say that you looked at before you really got to grips with, right, obviously bone is bone, it's quite obvious on ultrasound.
Yeah,
muscle. I mean, I've looked at a lot of scans now, so I can identify muscle versus
yeah,
pockets of filler. But
yeah.
yeah, how many scans did you look at before you sort of really got a grip of it?
I would dozens of scans. I do a lot of work with lips, so I tend to be more proficient in areas where I work in, areas like the lip area. So that's not too much of an issue. Areas like the temples, a lot more intricate tissue layering in the area, like the temples. So it takes a lot more work to try and figure out what you're looking at, the different planes involved where filler could be. You're looking
Yeah.
at a lot more structural tissue. So it takes longer to try and decipher what you're looking at. But I would say it would take probably, for me, to work out on the CGI, I would have had to go through a couple of dozen of scans before I was more confident in being able to identify the tissue more accurately. Even then, I still asked for a little bit of help and guidance from the likes of Leonie and Carolina because I'm never 100% sure. So there's always somebody that knows enough about the subject to be able to give you a little of help, and that's what I relied on.
Yeah, Dr. Jose is just saying it's just anatomy, but in grey scale. Yeah, it's like doing a jigsaw puzzle, isn't it? But all the pieces are grey. You have to
once
work
you
it
get
out.
once you get used to it, I think your eyes get accustomed to different tissue, different shades of grey, different movement of grey lines. When you see it again and again, I think you get more proficient in being able to identify what you're looking at.
Do you
But
think though that because we had this discussion before you got the ultrasound, because obviously
yeah,
I bought mine first and then you got yours. Not that makes me any more proficient in it, but you had actually, I think we'd had this discussion where you said I'm going to do a course first,
yeah,
but in
yeah,
hindsight, do you think? I think from my personal point of view that if someone presented me with loads of scans to look at, I wouldn't make that kind of connection with the anatomy. But because of
no.
that neural programming, like basically I'm holding an ultrasound, I'm looking at stuff, I can see it. Do you
Yeah.
think that is the definitive in terms of helping to learn that you've got to actually physically put the ultrasound on
You do.
someone's?
You do because until you actually physically use it and you can see how the image changes on the screen, it doesn't mean anything to you. You're just looking at dots. You're just looking at shades of grey. And to be honest, if you don't know where the scanner is in your hand, you don't know what you're looking at to begin with. So it really needs practice, and it just needs a lot of regular scanning before
Do you
you
think
get more accustomed to it.
is that going to be the name of our new course, 50 Shades of Grey?
50, yeah, well, I can't think of a better
No,
name
we'll
for
get
it.
into
Yeah.
trouble. No, no. We'll get into trouble. I think that's copyrighted. No, 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 no. We can't. We can't. That's a joke. That's a joke. 50. We'll have to. Yeah, 60 shades of grey, maybe.
60 Shades of Grey. That's
Yeah,
that's
yeah,
that's
yeah, yeah.
more resolution, I suppose. It's high resolution.
Well, that would be the
Um,
sequel, wouldn't it? More. Yeah.
yeah. But it's been interesting. I think it's myself and Leonia. We've been talking about what things could progress in the whole world of using facial ultrasound. And Clarius, I've been speaking to Clarius a little bit about what their plans are for the software and how it could be improved. So hopefully we'll be able to speak to them. Myself and Leonia will hopefully speak to Clarius about their plans for utilising artificial intelligence in ultrasound scanning. So they may well look at the options or the possibilities of using something like colour coding, colour overlaying on their scans to make visualization easier. And Leonie's got a whole load of ideas about how things could be improved. So we'll hopefully speak to them soon about that.
I think the issue is. I mean, we're digressing slightly, and I'm just being a little bit controversial. I'm going to pick a fight with you, basically, because I know this. But basically, I think what the problem is for software, basically, because obviously Claret is software, isn't it?
Yeah,
The ultrasound is the ultrasound. It's the software and it's the diagnosis. I think what you have to be really 100% certain on is when you color code it and CGI augment it, you as a practitioner are making that decision. But
yeah,
how accurate would AI have to be? Because in real-time scanning, for
yeah,
the AI to incorporate color augmentation to help the
yeah,
practitioner, basically the AI is then making the diagnosis essentially,
yeah,
which
yeah,
I think if when you do it in retrospect, it's you doing it, and obviously that comes with all the Viv experience and passion. Whereas with the AI, I mean, I think they're so far off it, Viv. I don't think if Clarice are watching, you know, they need to speak to practitioners like you who are manually doing it, and they need, I mean, if they can't, if they need to speak to people like you in terms of getting those scans in, and whatever algorithm the AI would eventually be based on, it has to be built on hundreds and hundreds and thousands of scans. I think for it to be approved to, I mean, what kind of specificity would you have to, and sensitivity would you be looking at? That's really, really tight.
It's difficult because everyone's different in how they carry out the scan.
Exactly,
so
exactly.
The software needs to compensate for differences in how one person scans compared to another one. So some of the work may involve actually helping the practitioner to orientate themselves more effectively, you know, to get the scanner in the right position for the software to be able to work. So some of the actual AI isn't just related to the actual image augmentation, it's related to the actual use of the scanner. So
and look, listen, you just nailed it. You absolutely nailed it. So, you know, everyone who's offering a course at the moment, there needs to be, and I know that Leonie, and I think the other course that you went on, and you know, it's that standardization of gripping and placing the ultrasound, because like anything in aesthetics, unfortunately, it is practitioner dependent. So you're exactly right. The courses that are now going out, first principles, they really have to focus on just literally how do you hold the scanner, because otherwise, just like you said, the image that you're viewing will change by millimeters, and then we'll go on.
But based on artificial intelligence, with a system that may be trained, we're getting a lot of hearts from somebody. Somebody's liking what we're saying. But based on the artificial intelligence technology, one of the things that I think will be developed is a method of assessing how the scan is being used. So the software will want to see a particular type of scan. It will expect certain tissue to be there when you're doing a scan on an area. And if you're not holding the scanner and creating an image based on what it's expecting, then what the software is likely to do is make you change the way you're orientating the scanner. So it produces a control image which it recognizes. And that alone is difficult to do.
So, but that is the first step that Clarius or Philips or whoever it is building these scanners. You know, for actually what we're asking for then is that they need to build a training software where you can. They've got a bank of images. Let's say, for example, temples, or masseters. And then they need to have a bank of images that you then put your ultrasound scanner onto a masseter or temples. And then it basically, until you get it right, you don't get a green tick on your scan. And that's what I mean, you could literally do that virtually. So you could have Clarius or Philips, whoever, anyone watching right now, you know, whoever you are as an ultrasound manufacturer, if you have a bank of scans that are perfect, you then need to help us as individuals who are training to then be able to, like, how can we match that? And that's a simple AI algorithm, because literally all that algorithm is saying, this scan now matches it. And then for us as human practitioners, we will then literally lock that into our brains and say, okay, I've done this so many times now. This is the perfect temporal image. This is the perfect image of the SMAS. This is the perfect image. And, you know, that's what the initial training needs to be from these manufacturers, rather than just having someone demonstrate it. Because, you know, it's like that old school kung fu kind of image, you know, with the master going along and smacking you on the hand until you get it right. Jose's just saying, even basic things like the amount of gel. Literally. The first step of that training scan would be, have you got the right amount of gel?
And that is where the likes of artificial intelligence could be used to improve the practicalities, the actual physical movements that a person has to carry out to get the scan recorded properly, because until you can do that, you're augmenting rubbish. And I augment Leonie's work because it's fantastic to see. You can see the tissue. She knows what she's doing. But it's people like Leonie, people like Rosa, Carolina. It's specialists who know what they're doing and know what should appear in the scan. They're the people that should be helping, or that could be helping, the likes of Clarius Phillips, GE,
I think they would gladly. I think they would gladly assist those manufacturers for free if required. But I think the manufacturers need to basically step up from just basically flogging hardware and start engaging properly with practitioners.
There's so much that could be done to improve the way we work with technology. And when I was at university, I did postgraduate in looking at how clinicians use technology in their work, and majority, over 95%, weren't trained in using system software for their work. They were just guessing and relying on other people to help them. And if this happens in aesthetics with the likes of ultrasound, it's just not going to make things better. People aren't going to improve, and they're not going to get scans that are going to be that are easy to read for themselves or for anybody else. So I foresee artificial intelligence initially helping practitioners to scan more effectively. That's the basics.
I think you nailed it. So I mean, basically, if they had an algorithm where as soon as you hit the right scan image, it locks it in for you. Because at the moment, you know, it's the same with aesthetics. You know, we inject, you know, we get taught on the nasolabial folds, and we find out that actually that's probably the most dangerous place to inject anyway. But, you know, it's over time that we build up that skill and technique. But imagine if the needle could actually glow green when you're actually in the right place.
Oh, yeah. Well, the thing is, in devices, you know, like your mobile phone, you've got potentiometers in there, so they can work out the angle that the phone is held in. So when you walk around, when you do exercise, the phone can tell what angle it's tilting in, and the speed at which the tilt occurs tells it how many steps you've taken. Now, the same technology could quite easily be used in the likes of ultrasound scanners. If you had rapid acting potentiometers in a scanner, it would know the angle that the device is being held in. That can be recorded electronically.
But even a pressure monitor at in the casing around the ultrasound crystal itself, so the probe. Obviously, the whole thing comes into contact. If you had not a tympanometer, but a pressure gauge, you know, that there is enough. I mean, if an iPhone can have that level of technology in it, why are the manufacturers not building that into the handset?
The problem is manufacturers, the programmers who program systems. I know, because I've programmed previously. Those programmers don't actually use the devices themselves. And the problem with that is it doesn't let them improve the system sufficiently based on what it's being used for. If the programmers had some experience of doing aesthetic treatments and carrying out scans, they would be far more progressive in improving their software. But unfortunately, that just isn't the case.
I mean, I don't think it would take much for an engineer to be presented with a problem where you said, look, here is your ultrasound probe. We need a potentiometer, like you said, so that the speed and the acceleration of which way the probe is being moved can be measured in software. And then also pressure monitor within the casing of the probe itself. And it wouldn't take much for it to, you know, ping when you're in the right place. So, and also, you know, why isn't it that when we're vascular mapping, you know, sometimes that, you know, it's fleeting when you see that superficial temporal artery, and you obviously want to know roughly where it is. Again, how hard would it be for the software to ping back to you? You found something of significance, and
if a system could be developed to actually map accurately the face. So, say you have to find some particular points that are related to an area of anatomy. If those points could be detected by the scanner, it can create an orientation point that's a standard control point, so it knows exactly where it is. If it knows where those points are, multiple points across the face, as you move the scanner, it could actually create a map of the face quite quickly, and it would create a plan of tissue for you based on what it's picking up. I was talking to Stuart last week, Stuart Taylor from Vino, and their
for anyone watching, Vino is...
Vino's the ultrasound scanner. It's a company, and they create scanners. And Stuart Turner, he's an importer and distributor of those devices, and their software allows 3D imaging based on 2D progressive scanning. So it'll work out, it'll join the 2D scans together to form a 3D image. So that's one method that's used to create a plan. But if software developers could actually put the brains together, they could create a system that would map a facial area as you were scanning, and it would, if it was done properly, it would make sure that your orientation was accurate for it to be producing an image accurately. It needs control mechanisms. It needs to detect.
Imagine this. Okay, so let's say this is what, imagine, because we're all about regulating, we're not regulating, we're all about making it safer for patients. So imagine, you find an aesthetic practitioner, and we've got a few who are watching us now. You've got a new patient coming in. Guess what? As part of your consultation, which they pay for, obviously, because there's a fee involved, you're able to do 2D to 3D mapping. And let's say they're interested in dermal fillers. You, as a practitioner, know whereabouts you place that filler. Well, guess what? From that 2D to 3D mapping, you run it through the software system. The system then actually identifies the amount of filler that is actually probably required from experience, from the tissue density, how much roughly would be required. So you're going beyond that whole MD codes where, so if anyone watching, there's a lot of us learn when we first start off, MD codes are codes where you should place and how much. But imagine if those codes were then mapped to 3D mapping, you'd be able to produce a report for the patient. Not only do they actually, now I understand that I need this amount of dermal filler, which is not just based on finger in the wind, but it's actually also going to help every single practitioner to go, right, I don't need to, I can budget fairly for this patient. And then equally, when your repeat patient comes in, that same software is able to pick up existing filler. Now, I did fillers today for a patient who I hadn't seen for a year. And we scanned over the cheeks, and the lateral projection just over the apex of the cheek, guess what? She had pockets of filler there. So do we need to put filler there? No, but we needed to put it before and after. And, without ultrasound...
I had the very same issue over the last few days. And actually, tomorrow I've got a patient with a complication from elsewhere who's had a filler in the cheek. And what happened was she had inflammation, apparently. I'm seeing her tomorrow. And she mentioned there was some swelling there a few months after the cheek filler was injected. Other side was fine, but one side there was a problem. And she went back to the practitioner. Practitioner thought it's probably filler that's not in the right place. There's some issue with the filler. We'll dissolve it. So carried out dissolution with high hyaluronidase and some improvement, I think, but it still wasn't completely clear. There were still areas of inflammation, redness, soreness, and it comes and goes, she said. And I'm going to be doing an ultrasound scan on her tomorrow when she comes in, and I'll be able to see if there's filler and where it may be. Because what I think might have happened with this particular patient, there may have been formation of a biofilm, a little area around the filler that may be caused by infection. There might be some of the reasons for biofilm formation. And the problem is, you can't dissolve a filler completely when it's encapsulated by material.
So how long has she had the problem for?
I think it's been a number of months now. I'll be finding out.
This is the thing. So look, we're very open here. I've had a recent case where the breakdown of filler caused an immune-mediated reaction. Now, if we'd left that, she would have had a granuloma. But the fact is, in fact, I've got the picture here. So I don't know if you can see that. So the top picture is, can you see that, Viv?
Yeah, I can see the rays.
So this is on the lower jaw. The top picture is basically a well circumscribed area, which is basically the hard palpable mass, which was only literally a week old. But the second picture, I hope you can see that. You can see that it's a lot less. It's less well circumscribed, and actually it's more in keeping with muscle that's there. So actually, we caught that within a week. Patient was able to come in. It was over a 2-week period. What we did is we prescribed steroids to help reduce the immune mediated reaction, and then we dissolved over a very staged and precise process. But exactly that, you're gonna ultrasound it. You're gonna see something similar, but probably even more well circumscribed into the granuloma, and then you'll be able to probably do ultrasound guided treatment. But the question is, this is for any patients watching as well, or practitioners. Don't be afraid of going and checking in. Sometimes it's better just to check in. As practitioners, we'll take that call and it will be like, well, could it be something else? But we all read the consent form when we sign it, and it does say in there that delayed reactions can occur months later. It all depends when that filler's breaking down. We just don't really fully understand how hyaluronic acid acts in vivo.
It brings us on to the next little part of our live tonight. It's looking forward to the practitioners who we will be speaking to over the next few weeks. Actually, Sunny, I'll go through. We've got about 5. We've got 4 of them, and there's ourselves as well. But we've got Dr. Barbara Parder, who's coming up next week, and she's a cosmetic doctor in Poland. She does a lot of training work. She uses ultrasound, and she does lots of work with patients herself. So it's going to be interesting speaking to Barbara next week. We've also got a doctor based in Argentina, Dr. Patricia Barrera, who's a dermatologist, and she's only recently started using ultrasound. And it shows what a small world this is, Sunny, because she follows me and I follow her on Instagram, and she also uses CMAC, the Complications Collaborative that we're both members of in the UK. And she posted, about a week ago, she posted some photos of a lip treatment that she'd carried out for a patient. But she wasn't sure if there was a possible blockage of vascular occlusion because of the discoloration in the lip tissue. So I messaged her just to say what I thought, looking at the photos. And Steve Weiner was there as well. He posted on the CMAC
I saw this
forum.
post. Yeah, it was really good. It was really good.
It was interesting to hear different views of the subject. But afterwards, like a few hours later, I had a message from Carolina Marilewis in Argentina. And she said, Viv, can I just ask you a few questions about the Clarius and connecting it up to do a live connection between 2 practitioners? And I said, yeah. It's not to do with a practitioner in Argentina called Patricia Barrera, is it? She said, yes, it is. And so I was speaking to both of them about the same problem, and they managed to actually sort it out quite quickly. But we'll be speaking to her in a couple of weeks' time about the whole case that she was involved with, involving lip filler treatment and using ultrasound to assess a problem before the potential need to treat it. So that's going to be an interesting evening doing the live with her, I think. We've also... Sorry, Sunny, what were you saying?
No, go on, because I've got a question from someone. They've on that note. But finish off. Yeah. So that's Patricia. Week after, we've got a lovely doctor called Olga Liplavic, I think she's called, and she is a PhD student at I think it's at Rotterdam. I think she works with Leonie, Dr. Leonie Schelke at Erasmus Clinic. It's Netherlands. It's
Rotterdam. So she's doing a PhD looking at dermal filler degradation, how it breaks down. So it'll be interesting talking to her about her work, also involving ultrasound. We've also got, very pleased to have Morbin Master, who's probably the radiology specialist, the radiology specialist who looks at aesthetic complications, dermal filler, breakdown over many years. I think he was one of the first radiologists to assess dermal filler longevity in patients, following them up over a number of years. So he's going to be joining us in a few weeks' time, and he's based in Australia. He's a radiologist and a doctor and does a lot of aesthetics work as well. So it'll be interesting to speak to him. And also, finally, myself and Sunny, we're both over in London in about 3 to 4 weeks' time. November the 19th and 20th, we're at the CMAC conference in London, and we'll be joining a lot of the practitioners who we've been speaking to over the last couple of months as well. So it'll be a great time to spend, and we'll be going out on one of the evenings as well. So we'll hopefully do a live from there when we're there. But it's going to be interesting. We'll be speaking to a lot of people, and we'll try and get a live done whilst we're there as well.
We've got Dr. Harris watching as well, so that's really nice. Thanks, Dr. Harris, Stephen.
We'll see Steve whilst we're there as well.
Exactly. No, so I think the question was, and it might be for one to answer on the download, but I think it was from a practitioner in actually Middle East who's been watching us, and she's purchased an ultrasound. So I think she's saying, I can share my Clarius exam and take a decision from an expert, but not sure how to do it. So we'll follow up, or Viv, I'll get Viv to follow that message up, because you've done it, haven't you? Have you done the link? Yeah. So yeah. So,
it can be a bit tricky when you first do it, because you have to break your Wi-Fi connection with the device, and it can cause problems when you link to the device directly. It's a bit of a faff around trying to do it, but it does work. But I'll get in touch and sort something out.
That might be actually a good live for us to do in clinic, where we can demonstrate one of us is scanning, and we can do that. So yeah, definitely. I mean, obviously, demand for it, so we'll do that for you guys, depending on the timing. So yeah. Awesome.
I think that's pretty much it. I think we've covered what we've been doing, we're covering what we're going to do, and we'll be continuing with different practitioners. We'll try and maintain a weekly live session every Thursday, but it's been interesting. We've been doing it for 6 months now, and we've regularly been going through the whole idea of using ultrasound in aesthetics. So I think hopefully viewers will be enjoying it, and hopefully they'll enjoy what's to come in future as well.
I never know with Instagram, because people, I mean, obviously Lynette, thank you so much, Lynette. You always watch and give us encouragement, and obviously Dr. Harris as well. Dr. Jose, thank you. I got to give a shout out to Angelica, who's our account rep from Get Harley, who also have a vested interest in making sure that, you know, as practitioners, we're offering the best in terms of skincare. Little plug there for you, Get Harley. Hope that's all right. We've got Dr. Natasha Clinics watching as well. Yes, we've had quite a few people watching. Can't not mention from Crop England, Jackie. I'll be talking a lot more about CBD over the next month or so. And that's in conjunction with Crop England. But yeah, I mean, I never know when people are watching how long they're actually on for.
Yeah.
So, but yeah, no, good. Viv, I've enjoyed it. You know, the future of aesthetic ultrasound. Any Philips are watching, or Clarius, you know, you heard it here first. All we want is we just want improvement and innovation. It's all about being, about furthering the industry, basically, and outcome.
As I was saying, I was talking to Clarius a few weeks back. I was in a video chat with their developers, the artificial intelligence developers, and they showed me their idea of using artificial intelligence augmentation, you know, similar to what I've been doing it, but doing it in an AI system. And I was looking at it, and I showed them what I'd done, and I think they were in a bit of shock after I showed them what was possible. So I think there's a long way to go before there's going to be good improvement in what's available to practitioners in the future. But it will happen. It's just a question of time. It needs testing. They need practitioners to be able to provide data to them. So one of the things that I spoke to them about was the need to have practitioners provide data from their scans, which is which forms a database, you know, that will be used by artificial intelligence
But
system.
I think that's where we said from the first principle is that we need as practitioners to be actually taking good images. Like you said, you've got some rubbish images. You know, we're not trained sonographers. We're doing this at as fast a pace as we can, but that's good. Viv, I think we've spoken at length. We don't want to make this live too long, otherwise people won't watch it to the end.
Well, it's nice catching up again, Sunny, and we'll catch up next week. Next Thursday evening at 8:30, we've got Dr. Barbara Parda from Poland, and we'll enjoy a good chat with her about ultrasound anaesthetics. So thanks again, Sunny, and I'll catch you next Thursday evening again.
Yeah, speak to you soon. Thanks everyone for watching. Good night.
Yeah.
Bye-bye.
Thanks a lot. See ya.